Hello, my name is Dan Resnick. I'm a neurosurgeon at the University of Wisconsin and live in Madison, Wisconsin.
Hi, my name is Mike Wang. I'm a neurosurgeon at the University of Miami in Miami, Florida.
Hi, Mike. It's good to talk to you again. What we're talking about today is really some of the work that you've pioneered in terms of the enhanced recovery after spine surgery type stuff. I was wondering if you could maybe just give us a quick thumbnail sketch of the background of this type of effort, and maybe some of the things you're doing in particular to try to promote the use of such technologies, both at your place and then also on the national scene.
Well, thanks, Dan, and thanks for having me here at NAS in 2019 here in Chicago. It's been a great meeting. I will never forget the meeting when we were talking about ERAS, and I think it was like 5 years ago. And we realized that it was the perfect setting because NAS, being an interdisciplinary spine-focused organization, is the perfect venue with which we can address this concept of enhanced recovery. And if I look at the Western Europeans that have started this, say in colorectal at its origins, the idea was to track the patient through the surgical journey from the beginning to end, not just the surgery, all the way to the end of recovery. The second is to be focused on improving that, which is to, basically try to make life easier for them, less pain, quicker mobilization, less cost, less hospitalization. The third aspect was that it had to be interdisciplinary. It's not really technique driven. It's not like minimally invasive spine surgery. It's like, how do you make all spine surgeries, better, right? And the last part is it's an iterative improvement program. So that means that you kind of study it, you change it, you tweak it, you study it again. And the interdisciplinary part was especially relevant to NAS, being as how anesthesia, physical therapy, nursing is all involved in the society.
Yeah, I agree. There was a very good presentation yesterday from the group in Michigan showing that for every 30 feet that a patient walked immediately after surgery, they could predict a third of a day decrease in length of stay. And I guess the question is, that's an association. What sort of things do you think that we can do during the either preoperative, operative, or postoperative period to encourage earlier mobilization and a more rapid and pleasant experience for the patient in the postoperative period?
So that's a great question. I would tell you, again, if we look at the parallels in ERAS and other surgical fields, and there are many, the most recent is in hip and knee surgery, there are many factors that go into trying to get people to recover quickly from surgery. And I'll just make the emphasis on this not being sort of technique related. In other words, one of the core tenets of ERAS is that you can take ERAS to any country in the world. And so it's not like I've got a special technique or widget, right? Because that can always help you, right?
It's a generalized pathway that's iterative that you adopt to whatever you're doing.
Right.
Be it deformity surgery, be it MIS, discectomies, endoscopic, whatever, right?
Right, exactly. And so it's a philosophy. And I would tell you that the core basis of it has something to do with less physiologic or homeostatic disruption of the patient, because surgery is very traumatic. And anything you can do to reduce that physiologically or physically is helpful. Good example is, carbohydrate drinks before surgery. So we are so used to keeping people MPO before the operation and then feeding them later. But in ERAS and colorectal, for example, they're giving people carbohydrate drinks, shortly before surgery and shortly after. And I don't know what the exact parallel will be for spine surgery. I think it's more focused on pain control and physical therapy. But that's what the research effort's going to be in, and international ERAS guidelines are going to be coming out hopefully in 2020 out of the U.S. and Western Europe. But I think groups like Michigan, I know Shiraz Qureshi at HSS is doing work. Neil Malhotra at UPenn is doing great work, and we've been trying ours, and I'm sure in Wisconsin you have your own programs as well that are successful.
We do, and things work differently in different places, so not everything that works well in our place would necessarily work well in your place, because we have different patient populations, different procedures. But just we've been talking sort of about the 30,000-foot view to some extent. Any concrete tips for those who are routine spine practice, looking to, what sort of things can they do to incorporate this into their everyday practice?
Yeah, I think that the team building aspect is critical to ERAS. I'll give you an example. We're launching our new order sets this week for spine surgery. And what it did was it brought together the nursing care, the physical therapy, and the doctors. And if you look at something as simple as like, when do the physical therapists see the patient? They see him once or twice a day. Right. Is it coordinated with nursing or done independently? Are they medicating people before they have their therapy? These, as you know, you see every day. Someone tries to get up with therapy, they didn't get their pain meds, so then they didn't walk, and the therapists don't come back that day.
Right.
Right, and those are very, very simple administrative aspects of ERAS without even getting the physiology. That's human resources, right?
No, you're absolutely right. Trying to coordinate the different caregivers so that the overall treatment plan makes sense is important and probably one of the hardest things to do. And I think you're absolutely correct in the concept of team building and better communication. As we heard at the talk yesterday about the symphony orchestra, having to have professionals do their job at the right time is a key component.
For us as spine surgeons, certainly I think, you think of yourself as the conductor or the center of all this, and I think that is important that there's ownership. In many fields, other specialties, I should say, have taken the lead, whether it be anesthesia or physical therapy. I think that we will not know exactly what's going to work best for spine yet, but I think at least at the outset, I think spine surgeons should take the lead. You mentioned some upcoming guidelines for the use of ERAS coming out. Any insights into what we might be able to expect from that? Yeah, I think that I'll give you a very simple example of where the rubber meets the road. There's a lot of controversy in, say, lumbar fusion as to whether or not you should be giving anti-inflammatories,
right.
Celebrex, stuff like that. And this is a point at which you'll probably see that the literature shows that it's probably not terribly harmful, and there probably is a lot of benefit. In terms of whether people will really adopt that or not, that's a personal choice, right? Mm-hmm. But I think that when you see the guidelines, you'll see many aspects where evidence is lacking, and I would issue almost like a clarion call to our NAS membership. This is an opportunity. If you look at, as I think you taught me this when I was a fellow, you look at any guidelines, and it gives you the guidelines, but it almost tells you where to do the research next, right?
Yeah, whenever you see an inconclusive conclusion, it's like easily published paper.
Yeah, exactly. That's exactly right. So for the people listening, think about that, and not just in America. ERAS should be translatable in Australia or Denmark or Japan.
Yeah, and I think the other message is that you don't have to be doing MIS surgery through a tube or endoscopic stuff. These same principles can be utilized for any type of spine procedure, any type of spine patient. Where there is some sort of intervention performed.
That's exactly right. So if anybody who's interested in this, I encourage you to look at the hip and knee literature. The guidelines are going to be published, I believe, at the end of this year. And it's going to be an ACTA orthopedic, I believe. And so if you look at hip and knee, they share some of the problems we have. It's not exactly like spine surgery, but it's more similar than, say, colectomy.
Right. Just in terms of the patient populations and who we're treating and such.